I'm Jung-Min Ahn from Asan Medical Center, South Korea. My topic is preventive therapy of the lipid-rich vulnerable plaque. So this is my closure. I'm here to become a DCB believer. So what is the established role of PCI? Because of many randomized trials in the patient with HES, the reduction of cardiac death, MI, is the role of PCI. In the stable coronary artery disease, angina relief is the main role of PCI. But I do believe that in the near future, the preventive PCI would be some indication. I'm expecting and I hope the role of contemporary PCI. So the preventive interventional cardiology, I want to be in the near future. So there was the preventive effect of stenting in stable angina. I don't think so. Regarding the all-cause death, based on the 3 randomized trials, COURAGE trial, FAME2 trial, ischemia trial, no difference regarding the. Sorry, can I have some point? No. Okay.
What do you want to do?
Okay. This. Okay. This. So the COURAGE trial and FAME2 trial, ischemia trial, regarding the all-cause death, don't give difference. However, so we look at deeply. The crossover rate, revascularization in medication group is up to 51% in FAME2 trial. In addition, reduction of spontaneous MI consistently across the different studies show that 30 to 40% reduction of spontaneous myocardial infarction. So I want to say that the reduction of spontaneous MI, it is a kind of preventive effect of stent. So in addition, regarding the overall MI in ischemia trial, no difference between the conservative and invasive strategy, but look at the innovative complex PCI trial. If you use intravascular imaging and more optimized stenting, we can further decrease the risk of invasive arm. So definitely, even in ischemia trial, we can show the reduction of overall myocardial infarction. So anyway, last 2 decades, we can define the high-risk plaque in vivo. We have several invasive coronary imaging, grayscale IVUS, and VH IVUS, and OCT, and NIRS. So there are something wrong in each device, intracoronary imaging. The coronary event increased. In addition, some combination of adverse plaque characteristics increased cardiac event further. So another interesting point is that initially vulnerable plaque, we thought that it was located in the very mild or non-stenotic disease, but more recent data suggested that vulnerable plaque frequently located in the more significant stenosis. So we measured the main FFR. So we had a large FFR registry. Even FFR is negative. FFR matrix is very simple. FFR is less than 0.80, stenting is justified. More than 0.80, medication should be medical treatment. But even though FFR is more than 0.80, some patients suffered from the cardiac death MI TVR. But event rate is very rare. At 3 years, based on our registry data, 3 years, around 3 to 4% of patients suffered from cardiac death, MI, and TVR. So the last 2 decades, what do you know about the vulnerable plaque? We can define the high-risk plaque in vivo using intravascular imaging. Intracoronary imaging defines the high-risk coronary plaque has more tendency to increase the major adverse cardiac event. However, what we don't know yet, can it prevent the future events originating from vulnerable plaque using local treatment? What we didn't know. Previously, at least the 4 small randomized trials, the preemptive revascularization with the stenting. This is the most famous randomized trial, prospective 2 trial. They used the BRS because regarding the preventive PCI, leave nothing behind the idea is very fascinating. So they enrolled around 200 patients. Actually, 180 something, numerically lower event in the group with the BRS and medical treatment group, but because of low statistical power, p-value is insignificant. So we designed the Preventive trial. Preventive trial is to compare the preventive PCI versus medical therapy alone for treatment of vulnerable plaque. So objective is to assess whether focal preventive PCI of non-flow limiting. Non-flow limiting means the FFR is more than 0.80. Imaging defined vulnerable plaque improves the clinical outcomes compared with OMT alone. Initially, we plan to use BRS, but after withdrawal of BRS in the market, we used the Giant stent. So this is the trial design. There is some coronary stenosis more than 50%. We measured the FFR. FFR is negative. We evaluated the intracoronary imaging. 2 out of 4 criteria met. We included the patient into the randomization, preventive PCI arm, and OMT group. Primary endpoint was target vessel failure at 2 years. So this is the definition of non-flow limiting vulnerable plaque. Coronary artery stenosis more than 50% and FFR negative, meet more than 2 out of 4 criteria. Initial 2 criteria was morphology criteria, minimal lumen area less than 4, and plaque burden more than 70%. The other 2 criteria was compositional criteria, thin cap fibroatheroma or lipid-rich plaque on years. The primary endpoint is target vessel failure, a composite of death from cardiac cause, target vessel MI, ischemic-driven TVR, and hospitalization for unstable or progressive angina at 2 years after randomization. This is the patient follow. We screened the 5,000, and FFR was negative, 3,000 patient. After imaging analysis, we enrolled 1,600 patients into 2 arms. This is the patient characteristics, very typical PCI per patient. Age is 64, diabetes is around 30%, mostly stable angina. Unstable and acute myocardial infarction was very rare. This is lesion characteristics, included due to mostly small lumen and large plaque burden in 97%, lipid-rich plaque located 28%, thin cap fibroatheroma 7%. In addition, QCA diameter stenosis is 57, so looks very tight stenosis, even though FFR is negative. IVUS measurement is very important. Minimal lumen area 278, and this is the preventive PCI characteristics. DES used 67%, BRS used 33%, only 1 stent implanted. Scaffold diameter is 3.5. Stent or scaffold diameter is 3.5, length is 23. All procedure was done using intravascular imaging. So this is the LDL cholesterol, controlled LDL cholesterol during the follow. LDL cholesterol at follow was 64, very low, comparable to the high dose statin therapy. So this is primary composite outcomes, target vessel failure at 2 years. At 2 years, OMT group 3.4. We have to remember these numbers. This could be the benchmarker for future preventive PCI trial. Preventive PCI with the BRS or Giant is only 0.4. This significance maintained up to 7 years. This is the lesion level analysis and patient-oriented composite outcome. Death from any cause, any MI, and any lipid intervention. Preventive PCI significantly reduced the patient-oriented composite outcome up to 7 years. So this is individual composite outcomes, primary composite outcomes, better in preventive PCI, death and target vessel MI, no difference, but the composite of death from any cause and target vessel MI at 2 years, primary endpoint analysis, significantly lower in PCI plus OMT group compared with OMT group. Numbers needed to treat with a preventive PCI were 45 patients to prevent 1 primary endpoint, and 87 to prevent 1 cardiac death or target vessel MI over 2 years. So ischemic-driven TVR hospitalization also reduced by preventive PCI. Subgroup analysis favored the preventive PCI at up to 7-year follow-up. This is conclusion. In Preventive trial, preventive PCI resulted in the lower incidence of MACE compared with OMT alone in patients with non-flow-limiting vulnerable plaque. Our key findings might provide novel insight on the role of preventive PCI on non-flow-limiting high-risk vulnerable plaque in the future. In addition to this trial, I believe that open new era in the field of vulnerable plaque research. Yes, I do admit that many limitations of our trial and concept of preventive local treatment. This is I.K. Jung nicely summarized why he didn't support our idea, the many things. In addition, there are many issues that we have to resolve in the future. Which imaging could be best for the preventive PCI? This is sub-study from the Preventive trial. We evaluated the minimal lumen, plaque burden, fibrotheroma, lipid-rich plaque. So multivariate analysis, we found that the plaque burden and lipid-rich plaque is significantly associated with the cardiac event. Lumen is not associated with the future event. So we only enroll the patient, small lumen, large plaque burden. So according to the lipid-rich plaque, efficacy of preventive PCI was different. Presence of lipid-rich plaque, preventive PCI reduced the event, but the absence of lipid-rich plaque, preventive PCI and medical treatment, no difference. This is due to preventive PCI reduced OMT in the lipid-rich plaque. The OMT group has a higher risk. But this is invasive procedure. So in the near future, I think we need more the non-invasive screening tools. And what is the good local treatment? In our trial, initially we used the BVS because we thought leave nothing behind is a good idea for preventive PCI. But and later we used the DES. But the BVS cohort, there was no difference regarding primary endpoint. But the DES cohort, DES worked very well, so maintained a very low event rate up to 7 years. And I think that the DCB would be a very good option for the preventive PCI because it also the very ideal for the leave nothing behind idea. But this year, we saw some sadness and hope for the DCB. Leakage-free trial show that the negative and solution trial meet the non-inferiority. But usually, the vulnerable plaque located in the proximity and large vessel. So leakage-free trial, proximity large vessel. This
we're running short in time.
Yeah, yes, almost. Yeah. So solution trial also a little bit higher event rate. So the Dr. Shin's ongoing trial, reverse trial, will give us some hint which would be good, the local treatment. In addition, bioadapter would be good. So anyway, nowadays we are planning the Preventive 2 trial. We consider the many aspects, screening, target patient, numbers, which would be a good invasive imaging or non-invasive imaging background medical treatment. This is our concept of Preventive 2 trial. We'd like to screen patients using CT and kind of ischemia trial, the invasive strategy and conservative strategy. Invasive strategy, I'd like to use DCB for the kind of preventive PCI treatment. So when our plan is more solid, I hope to tell you again in the near future. Thank you for your attention.